Hello, everyone, and welcome to CancerSpeak, the official podcast of Cancer, a journal of the American Cancer Society. I am Dr. Akinyemi Ojesina, the host of today's episode. I serve on the editorial board of the journal Cancer, and I'm also a physician scientist and an assistant professor of obstetrics and gynecology at the Medical College of Wisconsin. I'm very pleased to be joined today by Dr. Linda Duska to talk about her latest publication in Cancer that describes top advances in cervical cancer that occurred in the past year. I am also thrilled to be joined today by Linda Ryan, a patient advocate and 7-time cervical cancer survivor. Dr. Duska, thank you for joining us today on CancerSpeak.
I am so happy to be here.
Would you like to take a few moments to introduce yourself?
Sure. My name is Linda Duska. I'm a gynecologic oncologist at the University of Virginia. I am also a clinical trialist.
Thank you so much. Linda, thank you so much for being here with us today. I would love for you to introduce yourself to our audience as well.
Thank you. Thank you for wanting to have the patient voice in these discussions. I'll just give you a brief overview. I was originally diagnosed with cervical cancer in 2004, so 20 years ago. I've had 6 recurrences, and so I've been through many different treatments, including 3 clinical trials. I'm fortunate enough to serve on several committees, including the NCI GYN Cancer Steering Committee, the SGO and FWC Patient Education Committee, the Cervical Cancer Task Force, and also GCIC Cervical Cancer Consensus Conference. And I'm really honored to be here and grateful that you're wanting to hear the patient voice.
Thank you so much. Dr. Duska, can you share a quick summary of your commentary for those who have not had a chance to read it yet?
Sure, of course. Well, first of all, Linda, I love your first name.
What are the chances, right? The two of us are
I know,
here.
right? We have 2 Lindas on this call. It's so awesome. We must be the same age because Linda is a name from the 60s. So what I would say is that 2023, but also 2024, huge year for cervical cancer. So many advances. And Linda, to your point about having multiple recurrences, I would say 10, 20 years ago, we didn't have a whole lot of options for cervical cancer. And now we have so many. And I want to thank you for your participation, not only as a patient advocate, but also in clinical trials, because it is through clinical trials and clinical research that we make advances in cancer in general, but in cervical cancer in particular. So thank you so much for your advocacy and also for your participation. So many amazing studies that were presented this year in 2023, and then published in 2024 that we can talk about on this podcast that are so exciting and that have changed the standard of care for cervical cancer.
Absolutely. Would you like to highlight a few of these and perhaps some of the key findings for some of these clinical trials?
Sure. Well, let's start with the SHAPE trial. This was a surgical trial, and this is actually a really interesting study because this allows de-escalation, as we say in medical speak, for surgeries for cervical cancer. So the SHAPE trial really helped us to identify those individuals who don't need to have radical surgery for their cervical cancer, but can actually be cured with a much less complex procedure, a simple hysterectomy. And Linda, from a patient standpoint, this has got to be huge because radical hysterectomy has a lot of long-term side effects for young people who undergo this procedure. And so to be able to be cured with a less radical procedure, that's a very major advantage for these individuals.
I definitely agree with that. De-escalation is always appreciated, and being able to have something less invasive is certainly important.
Absolutely, particularly with respect to the quality of life considerations. Dr. Duska, I wonder, for that study, wasn't it the case that there were quite a few subjects that had pre-operational excisional procedures, and in many cases, there was no disease in hysterectomy specimens? Do you have some comments about how and what this means for being able to identify patients who are high risk preoperatively?
Yeah, so that's a really good question. You hit the nail on the head there. So you're right. 70% of individuals on that study had a preoperative excisional procedure, and almost half had no disease in the hysterectomy specimen. So this was a relatively low risk group. And so you're right about that. I think that we need to think about which patients we offer less invasive surgery to, because of course, this is a curative procedure that we're doing. So we want to make sure that we offer it to the right individuals. I think we need to await further analysis on these and other surgical questions in this well-defined low-risk group.
Thank you. I wonder if you could tell us a little bit more about what's happening in the locally advanced cervical cancer space.
I love this. So there was a huge discussion about locally advanced cervical cancer at ESMO, the European Society for Medical Oncology, in 2023, as you likely are aware, because two very important studies were presented. One of them was, I affectionately call it A18, but its main name is ENGOT CX11 GOG 3047 Keynote A18, but we'll call it A18 for short. This was a study where the immunotherapy or checkpoint inhibitor pembrolizumab was added to chemo and radiation therapy, which is the standard of care in subjects with high risk locally advanced cervix cancer. And the results of this study were presented. It was a randomized trial, and there was a statistically significant progression-free survival advantage seen. At the same time, at this meeting, the Interlace trial was presented. This study looked at a similar but different population of subjects with locally advanced cervical cancer and looked at giving chemotherapy, a short course of chemotherapy prior to chemoradiation therapy. This study also showed a progression-free survival advantage, but in addition showed an overall survival advantage. So this created a whole lot of discussion. The Interlace study has not been published. A18 has been published. And these data also, A18's data also need to be interpreted in the setting of the negative CALA trial, which was a very similar trial with some very important differences to A18. So let's start with A18 and CALA. There were significant differences between A18 and CALA that are important to note. The first is that the population of subjects was different. The population of subjects in A18 were at higher risk than they were in CALA, mostly because of the lymph node positivity requirements. The second main difference between the two is the agent used. CALA used durvalumab and A18 used pembrolizumab. When you look, and of course cross-trial comparisons are not legal, so we're going to pretend I'm not saying this, but when you look at the control arms for A18 and CALA, so the group that received chemoradiation therapy alone, control group in A18 did not do as well as the control group in CALA, probably because the population in A18 was at higher risk. So my opinion, that may be why the difference in A18 was statistically significant when the difference in CALA was not. That's just a theory. We have heard from the sponsor that overall survival is also significant. We have not seen those data yet. So I think we need to wait patiently, which is not my best thing, to see the overall survival for A18 to make any definitive decisions about that. The other interesting thing about A18 was the FDA chose to give approval to A18 only for those individuals with stage 3 and 4 FIGO 2014 disease. Now that decision was made based on a subset analysis, and we're going to have to wait and see how the overall survival data look before we can make any definitive statements about that. With respect to Interlace, the Interlace trial is very provocative, but I would point out that this looked at a very different group of patients than A18. It was a much lower risk group. The majority of patients had stage 2 disease. Now, again, this was a different FIGO staging system that was used for Interlace. It was FIGO 2008 as opposed to 2014. So it was a much lower risk group of patients, and also they were not allowed to have positive periodic nodes. They had a much lower risk of nodes being positive. So I think when looking at Interlace and looking at A18 and trying to make a clinical decision about what to offer a patient, it's really important to look at the patient in front of you when interpreting these results, because the two studies looked at very different groups of patients. And of course, I am eagerly waiting the OS data from A18 because I think that's going to change how we interpret that study.
Yeah, thank you so much. Isn't it also the case that the time frame was different and the type of radiation used, for Interlace was not the modern controlled radiation?
Absolutely. That is so true. Although one would think that the randomization in Interlace would have taken that into account. Interlace has OS data because it's much more mature than the A18 data, which reported quite early. So yes, absolutely true and a very good point.
So, Ms. Ryan, as someone who's been in multiple clinical trials, it's certainly important to think about how you would respond to multiple lines of treatment for recurrent and/or metastatic cervical cancer. Do you have any comments about that?
When I was offered my first trial, it was my first recurrence in 2011, and I didn't know anything about trials. I didn't know to even consider trials. And the trial that I was on was 2 drugs. They were seeing a 30% response rate. So there were 54 women on the trial, 17 responded, 16 had a partial response, and 1 person had a complete response. And I was that complete response. So it was at that point that I realized how important science was in trials, and I truly am sitting here because of it. So in subsequent recurrences, that was kind of the first thing I asked. Unfortunately, my doctor is very in tune with trials and things that are going on. So it's never been a question for me, but it has been an education in talking with other women because there are so many myths associated with trials. So it's been interesting to educate other women, but to also hear what their thought on trials are.
Thank you so much. Dr. Duska, as a segue, could you tell us a little bit more about some of the latest advances in first-line and perhaps second-line recurrent and metastatic cervical cancer?
Sure, I'd be happy to. But first, I want to echo what Linda Ryan said. I think I personally feel, particularly in cancer, that clinical research and clinical care are essentially the same thing. And that clinical research often gives people an opportunity to try something new and potentially better, and potentially, not always, but potentially to benefit from a novel therapy. So thank you for saying that. I think that's so important. And I also feel that educating people about clinical trials is really important. And even if they choose to do standard therapy, at least educating them helps them to make an informed decision. And so I'm a big proponent of clinical research, obviously. So in the second and higher line of therapy, we saw the results of the BEAT-CC trial this year, which confirmed the results of KEYNOTE-826. So KEYNOTE-826 is a platinum plus paclitaxel plus bevacizumab plus pembrolizumab. And we saw very similar results from the BEAT-CC trial. One might also even say better results from the BEAT-CC trial than we saw from KEYNOTE-826. I think when you look more closely at KEYNOTE-826, this is because KEYNOTE-826 did not mandate bevacizumab. And this is a very complicated conversation that will take more than the time that we have. But if you look at the individuals in KEYNOTE-826 that received bevacizumab and you compare them to the BEAT-CC subjects, there are similar responses. So I think we learned from this experience that, at least in this setting, the checkpoint inhibitor or the immunotherapy and the bevacizumab are very, very important both. And that if it is deemed safe to give bevacizumab, bevacizumab should be given. It's not safe for everyone, but it does seem to be a very important component of the care. We also saw the results of Innovate 301. This was a confirmatory trial for tisotumab vedotin, which is an antibody drug conjugate. And in this trial, tisotumab vedotin was compared to chemotherapy. We saw, as we knew, that chemotherapy doesn't have a great response rate in this setting. And again, that's why clinical research is so important, is for us to find novel therapies. We did, however, see that tisotumab vedotin had a high response rate, which is wonderful to see, even in those folks who had already received bevacizumab and who had already received immunotherapy. So really exciting results there.
Thank you so much. I want to move to something that is near and dear to me, which is the issue of diversity in clinical trials. One of the things that I think came up as you look through some of these studies is how, even though most women who are affected by cervical cancer are either women of color or they reside in low and mid-income countries, most of these trials continue to have low numbers of women of diverse backgrounds. What would you say are the challenges for increasing racial and perhaps geographical diversity and inclusion in clinical trial accrual, and how would we begin to perhaps address some of this so we can achieve our goals in this area?
Well, I'm interested in Linda Ryan's thoughts about this too, but I completely agree with you. Racial and ethnic diversity is critical. I also think geographic and socioeconomic diversity are critical. I think the pharmaceutical sponsors are trying their best to do a better job, but even in that setting, we're clearly still not doing as well as we need to do. And these novel medications are, to your point about underdeveloped countries or less developed countries, these novel therapies that we're talking about are really expensive, right? And making them available available where they're most needed, where cervical cancer is most prevalent, is also critical. I certainly don't have the solution to your question, but I do think that the patient viewpoint, which is why I'm very interested in Linda Ryan's thoughts about this, and also we as providers and sponsors of trials need to do a better job of reaching out to communities and engaging communities. We are still not doing a good job of that, in my personal opinion, and reaching out to those communities to establish a relationship of trust, reaching out to community leaders, engaging community leaders and communities and community health centers, and decentralizing the way we do clinical research in the US are all going to be critical components of improving diversity of accrual.
Well, I definitely echo everything that you said, but the one good thing that I will say, while we haven't made much progress at all, is everyone is talking about it and everyone is aware of it. So hopefully that will move the needle a little bit to get other people at least on board. And it's interesting, as a patient and a patient advocate, it's really great to be asked to be on these committees. And while I may not live in an underserved country, and I'm very fortunate in that way, hopefully the patient view and the patient reminder of what the patient journey is will make a difference in this whole process. But I agree, and I agree at the community level, if we could do more and get, whether it's community health systems or whoever involved, it's important that we do that. And if people like me or people who don't look like me just share their story and tell people about trials and about treatments that they've had, that will help as well.
Our host, what do you think? What is your opinion about this? How can we do better?
Well, I think you've mentioned most of the main points. I think certainly talking about it and making sure that we're aware of that diversity is certainly important. I think that working at the community level is really critical. Having people like patient navigators, for example, who would help and encourage patients to participate in clinical trials, identifying champions within communities who would be able to speak to the benefits of clinical trials. There will be a need for usually if you have somebody who is like you for whatever socio-economic circumstance, it's certainly helpful for those people to be advocates as well.
Can I just jump in again on that, where we're talking about the community level and the importance of people talking on the community level? This cancer is a cancer that we can prevent with HPV vaccine. So having that conversation on the community level is beyond important as well. My 2 cents.
I'm so glad you said that. That is so important. I should have said that too. This is a completely preventable cancer. So all of us need to continue to advocate for the vaccine. The safety and efficacy of this vaccine is something that we just need to do a better job of in the US and also worldwide.
I went to a Florida localized summit about eliminating HPV-related cancers, and there were a few people who spoke, one person from Alabama and another person in Florida, who are doing things on the local level. And I left there thinking, okay, I need to figure out what I can specifically do in my community to get this. And so I was energized by that. And I think that if there are more people who will do that, we can make a difference.
Thank you so much. As we begin to wrap up, I just want to ask if you have last words about, and I think we've mentioned so many things already, but last words about what key takeaways you think patients should have, either as they read the article or hear more about this. I'll start with Dr. Duska and then end with Linda Ryan.
Sure. So first of all, I would stress what Linda Ryan already said about this being a preventable cancer, either with screening or vaccination or both. We're seeing immunotherapy really move from later lines as a single agent into second line in combination to first line. And so I think as this is very exciting time for cervical cancer, and we are going to see continued development of novel therapies in this setting, particularly the antibody drug conjugates, which we talked about tisotumab vedotin, but there are other antibody drug conjugates in this setting that have shown activity. And it just really inspires me that we have so many novel options for patients with cervical cancer now. It's amazing. And this is a great time of innovation. And so it was absolutely my pleasure to be part of this paper this year.
Thank you so much. Linda?
I think what I would love for patients to know is that there are people like Dr. Duska working on novel therapies, and there are different things available. It's not just what you think of cancer used to be. You just get chemo. I mean, there are definitely other options, and I think that's really important for patients to know. I think it's important for patients to know that there are trials, but also the success of a lot of those trials and what we're seeing now. So I always have hope.
That's all the time we have for this episode of CancerSpeak. Thank you to Dr. Duska and Ms. Ryan for taking the time out of their busy schedules to join us today. And a very special thank you to you, our listeners, who tuned in to this episode. I encourage you all to read Top Advances of the Year, Cervical Cancer, now available in the journal Cancer. We will include a link to the report in the show notes. Thank you very much.